Are you tired at the end of the day? Are you stressed and you have no libido? Like, you just need TRT. And what guy isn't tired at the end of the day and occasionally has a swing in his libido? So every guy thinks that they need TRT. The benefits of TRT are actually via increasing estrogen, not the testosterone.
A lot of people assume that estrogen is the female sex hormone.
Right. Yeah. In that study, the guys who had lower estrogen had more adiposity, they had more body fat, and they had less libido and poor erection quality. So the more the estrogen went up, they got leaner, they got better erections, they had better libido. Sometimes guys do have very high SHBG, very low free testosterone, and they don't feel great. But a lot of times they don't. And symptoms are hands down the most important thing to think about when we're talking about testosterone. I'll repeat that the whole time.
Welcome back. In today's conversation, I sit down with Dr. Adam Hotchkiss, a podiatric physician and foot and ankle surgeon who in recent years has pivoted to helping clients, mostly men, optimize their health for vitality, feeling good in their day-to-day, and also long-term disease risk reduction. Part of this involves hormone optimization, with a particular focus on optimizing testosterone levels through lifestyle, supplementation, and/or pharmacotherapy. In this episode, you will learn what testosterone is, its relationship to other sex hormones, how testosterone levels in males are changing, what normal, healthy testosterone levels are, the difference between free and total testosterone, symptoms of low testosterone, testosterone replacement therapy and what that is, how nutrition, sleep, and exercise influence testosterone levels, whether testosterone-boosting supplements are worth taking, Adam's personal experience with steroids, and plenty more. Really an episode for anyone, but especially young men considering steroids to improve their physique, and men who want to increase their testosterone without compromising their fertility, as well as their partners, friends, and family to better understand their experience. Please enjoy. Did you get a lift in this morning?
I did. Yeah, kind of. I don't really like to work out on podcast days. I get a little brain fog.
Yeah.
Did more cardio.
Okay. Have you been to Gold's?
Never before. Yesterday was my first time.
Yesterday.
Yeah.
I bumped into you.
Yeah.
And
That was weird.
And Mark Bell.
That was super weird, dude, because I was literally saying your name. Mark's like, "What are you here for?" And I'm like, "I'm podcasting with Simon Hill." And I'm looking, I'm like, I'm pretty sure it's fucking Simon right there. Like, It was really weird.
Yeah.
I felt like I manifested you.
It's an interesting place to work out, isn't it?
It's super interesting.
Like nowhere else in the world.
No, it's a weird place.
You're a podiatric physician?
I am.
I didn't know that.
Yeah.
That might come in handy, actually. So,
Well,
yes.
Yeah.
Yesterday I got an e-bike delivered.
Oh,
The
nice.
Super 73. Have you seen those
Yeah,
things?
they're awesome.
Yeah.
Casey
And
Neistat.
I was like putting it together. Yeah, right. I was putting it together and thought I was being really handy. And then I needed to lift that thing down the stairs. And there was a box in the way and I didn't see it. And I tripped over the box and I dropped the entire weight of the bike. The kickstand was out and the entire weight of the bike went through the kickstand onto my small toe.
Oh, nice.
It's pretty gnarly. You
Yeah.
want to see it?
Yeah, let's see it. Here we go.
Show
This
it
will
on
get
the
the
table.
views.
I don't
Yeah.
I'm not sure whether this is good. Can you see that?
Oh, yeah. That doesn't look good at all, man. And they're painted.
I think, yeah, they're painted.
That
Yeah.
might be broken. It might be broken, but there's really not a lot to do for a broken digit like that unless it goes into the joint. Then sometimes we need to do surgery.
So like a compression, crush fracture, or
Yeah, it'd
if
be
it
like a
was
crush
break?
in your case.
Yeah.
But if it were to go through the joint, meaning like the break is into the joint, sometimes we need to fix it. But that's such a little bone. Sometimes we just leave it.
Yeah, it was pretty swell. There was like a bunch of removals around, and I just kind of gritted my teeth and acted like it didn't hurt that much.
Oh my goodness. That looks like it hurts right now.
And I'm meant to be going scuba diving next week, so I'm
that'll
hoping
be
that
fun.
inner fin should still be okay.
Hopefully.
Yeah.
Let's see.
So podiatric physician.
Yeah.
We kind of have just given it away, but what is that if someone's hearing that for the first time?
Yeah, so foot and ankle doctor, which is weird because we're going to be talking all about hormones, right? And so, when I actually got into medicine, I really wanted to do something with what I thought athletes, because I got into fitness, which kind of saved my life. So I was on a really bad trajectory and found nutrition and fitness, and it kind of changed my whole outlook on life and changed everything for me. So I thought, being a physician, I want to do something that's going to give back to that community and work with athletes. Quickly found out that in my profession, which is podiatry or podiatric medicine, foot and ankle surgery, about 95% of what I was doing was diabetic wound care. So, I'm dealing with people when their only treatment is basically amputation most of the time. So I was basically cutting feet off all day, every day, doing the antithesis of everything that I wanted to do, helping people with human optimization. I myself was an athlete and very, very involved in the PED space, performance enhancing drugs. So a lot of hormones, testosterone being the basis, and just had a large affinity towards that group and biohacking kind of. I was dealing with one patient in particular who had this recalcitrant ulcer. So I've tried everything on it. We're working for like 6 months to a year. I did grafts, multiple surgeries, wasn't healing. And I read a paper out of Russia talking about the effects of testosterone on wound healing in diabetic ulcers. And they took a hypogonadal man or a low testosterone man, gave him testosterone, healed the ulcer. So I called up this guy's primary care, told him, I'm going to run some, testosterone labs on this guy. And sure enough, not only diabetic, but also hypogonadal. And I, called the doc, like, do you have any issues with me initiating TRT or testosterone replacement therapy on this guy to see if we can heal? And the doctor's like, I don't really deal with that. I don't know a lot about TRT. Sounds like you do. Let's do it. We did. Within 6 months, his ulcer was healed. So this was like, and I was like, oh, there's something to this.
Is there literature on that testosterone can help with,
there's a few
with wound healing? Or
like that one in
healing?
particular, that one came out of Russia. I forget what year, but that was like a really awesome article that I read. And I'm like, oh, this is interesting. But we definitely know that testosterone increases growth factors, protein synthesis, all the things necessary for wound healing.
That's interesting because I think many people, myself included, at least for a long time, would just see testosterone as this hormone that's important for muscle function and size.
Right. Yeah. That's
and libido.
Yeah. And we'll get into all of the massive benefits of testosterone outside of that for sure, because they're, wound healing, cognitive support, mood, like you said, muscle, libido, all of that. But they're, multifactorial, immune function, so many things that testosterone plays a role in.
Did you say fitness saved your life?
I did. Yeah.
Yeah. What do you mean by that?
Yeah. So when I grew up, I didn't think that when I grew up, I had long hair, skinny jeans. I looked like a Ramon. I was a skateboarder, had no idea that I would get into medicine. I'm somebody who takes everything to like 110% if I'm going to do it. And even in my skateboarding, like I was idolizing skateboarders and punk rockers. Shouldn't have been, but for some reason going through like puberty, I kind of saw the punk rockers that I was looking up to and they were like skin and bones. And I developed anorexia nervosa and bulimia because I was trying to idolize those guys. And I didn't even really know that it was happening, but it was kind of spiraling out of control. Probably 16 through 20 is when I dealt with that a lot. So about 4 years of, just starving myself. I was 5'11", 130 pounds, and I thought I looked great. I thought I was awesome, but I didn't realize until I'm like choking myself, trying to make myself throw up after a meal that I realized, man, there's something wrong here. And then I got in a little bit of trouble with the law, just did something stupid. I was with a bunch of friends at a mall and I was like trying on a jacket and one of my friends dared me like, oh, just walk out of here. I'm like, okay, being stupid. You try to impress your friends when you're 18 or whatever. And mall security grabbed me, got a misdemeanor. But it was at that point I thought to myself, like, what are you doing with your life? I'm like skinny, bulimic, I'm getting in trouble. I'm just drinking every night. Like, what are you doing? So I shaved off my hair. I got a whole new wardrobe because again, 110% everything. So I just go fully into this fitness stuff. And I got really into physiology, anatomy. I enrolled in college and I just kept going down the path. Like, oh, I really like this science stuff. Maybe I'll be a personal trainer. I was a personal trainer. And then that wasn't enough. I thought maybe I'll be a registered nurse. And then I thought, maybe I'll be a physician assistant. And I went to go shadow a physician assistant and I met a doctor at this office and he said, I was a lot like you. I didn't go to med school until I was 35. And that was the first time I've ever heard that. I thought that in order to be a physician, you had to have been bred into it, from a family that floats around on yachts and you go to Yale or Harvard. I didn't know that somebody like me from a small little town that was a punk rocker, could have gone on. So I'm like, oh, wow, we talked. And I just went down that trajectory. And, in that, I knew that I either wanted to do orthopedic surgery or dermatology because those are my two favorite specialties. I was working in a dermatology office when a podiatrist came in. He came in to help us with a nail removal because podiatry does a lot of nails and so does derm. And the dermatologist needed some help from the podiatrist. And then he said, after this, I've got to go fix an ankle fracture. I'm like, wow, this guy just did skin and bones in the same day. Perfect. That's what I want to do. So I just went down that path. But then, as I alluded to earlier, I quickly abandoned that path after starting. And that was after Derek of More Plates, More Dates kind of had heard of me online because I was kind of in that community and he asked me to come along and kind of act as a health coach and a liaison through his company, Merrick Health.
Okay. So that takes you from having an interest in testosterone within the kind of setting of podiatry clinic to what you're doing today. How would you describe what you do today?
Today, I would say I'm mainly more of a health optimization coach more than anything else. I don't even really like to call myself a doctor anymore. It's not my scope. I'm certainly not an endocrinologist, no formal training in endocrinology, though, I saw a lot of your comments yesterday when you posted up, asking why are endocrinologists not good at TRT? And that's kind of a common thread, which we can dive into later. But yeah, I would call myself, I guess, a health optimization specialist or, a health coach of sorts. I really try to take a healthy person and make them healthier, or take a healthy person and try to do the best at preventing disease and improve longevity. So reduce all of these very preventable diseases like diabetes and ASCVD, things like that. And through that, there's a lot of testosterone involved because it plays such a vital role.
Yeah. So what portion of that is optimizing hormones?
Well, for most guys coming in, they think that it's the end all be all. And something that I spend most of my day doing is talking people out of TRT and telling them that they don't need it. I think social media in particular, and a lot of these TRT clinics have done a really good job convincing every guy that the solution to all of their problems is on the other side of a testosterone injection. When you look at the symptoms of low testosterone, there's so many differential diagnoses there, but it's like, are you tired at the end of the day? Are you stressed and you have no libido? Like, you just need TRT. And what guy isn't tired at the end of the day and occasionally has a swing in his libido? So every guy thinks that they need TRT. And then top that with all of the influencers that are now sponsored by TRT clinics who just look like Greek gods. And now you go, I'm tired. I don't look like him. All he's doing is TRT. That's all I need to do.
And did they really get there and get that physique with just TRT?
Right. And I would argue mainly no. And I have a very good insight in that, since that's the community I came from, the real steroid users, because again, 110%, when I got into fitness, I got into steroids at a large degree, and I kind of know that. And so bodybuilders are awesome because we really take everything to the extreme. So if you want to learn about hormones, you talk to a bodybuilder because they know it probably better than any other endocrinologist. It's kind of crazy. But yeah, I know that those people certainly didn't get there with TRT alone.
Let's define a few terms that we're going to be throwing around. So TRT, testosterone replacement therapy, that's a prescription form of testosterone to help people get into like a physiological kind of normal range.
Yes.
Then you just mentioned steroids. There's, I guess, just testosterone. Let's define the three of these. So TRT, testosterone, and steroids.
Yeah, that's something that I spend most of my time harping on, that I really want people to realize. Like, TRT is just replacing, as you said, to normal physiologic ranges. So that's not putting you into this grand muscle building capability, what we would deem super physiologic or above normal physiologic range. That's what I would put into the category of like steroid use. Testosterone does fall into that, but when we're talking about a steroid cycle of testosterone, that's usually anywhere from 3 to 10 plus X what a TRT dose would be. So just for reference, a TRT dose probably around 100 to 150 milligrams a week. There's bodybuilders who run 1,000 milligrams of testosterone a week, and then other compounds too.
So 10 times.
10 times. Yeah, sometimes even
typical
more.
HRT dose.
Yes. I mean, and your starting steroid cycle is usually about 5 times. Most people start with like 500 milligrams of testosterone, which is pretty high, but still 5 times a TRT dose.
And steroids is my understanding. Is that an umbrella term? So that includes testosterone, but then a whole bunch of other compounds.
Yeah. So steroids, when we're talking about it in this context, would mean, like illegal anabolic androgenic steroid use. Because steroid, I mean, like vitamin D can be considered a steroid hormone essentially, so there's a lot of different steroid hormones, but steroids as we're talking about them in their illegal use would be, things like testosterone and synthetic analogs of either testosterone or DHT or something like that.
And what does androgenic mean?
So androgen has to do with kind of the masculinizing effects of the testosterone. So testosterone has both anabolic, meaning growth, so bone growth, muscle growth, skin, maturation, and then we have the androgen part, so the masculinizing effects, both primary sexual characteristics like developing a penis and testes, and then the secondary like facial hair, chest hair, axilla, armpit hair, genitalia hair, oily skin, structure of the bones. So when you hear androgen, that's basically think masculine.
Right. And testosterone, that's a word that I think most people are familiar with. But what when you distill down what actually is testosterone?
Yeah, so testosterone is a hormone produced predominantly by the male testes, some by female, and some in our adrenal glands as well. About 3 to 5% of testosterone is made in our adrenals, but it's a hormone that signals to the body to have various effects. So we have what are called genomic effects, meaning it binds to the androgen receptor and helps in gene transcription, translation. That's things like muscle building and bone growth and skin growth, things like that. Then we have non-genomic effects also. That's where you hear about the mood effects like the nootropic or the cognitive function or the aggression or things like that would come. So it has these multifactorial, but any hormone is kind of just a signaling compound where it's produced one place in the body and causes a interaction in another place.
Right. And what's the role, I guess, of testosterone at the site of skeletal muscle?
So it will help to grow it for sure. So it helps to increase, the protein synthesis. It can improve the amount of the satellite cells that go on to build muscle. It can certainly help with strength, especially its metabolite DHT, dihydrotestosterone, very good for strength. So not only are you, increasing your ability to move more weight, which is essential for muscular hypertrophy, then you actually, the testosterone binds to the receptor and causes the transcription, translation of new DNA to build more muscle.
So testosterone acts as a precursor to DHT.
Correct.
And DHT is important for strength.
Mm-hmm.
I don't want to kind of go too far down the weeds on this, but just quickly while we're here, finasteride is a drug that a lot of people take,
correct,
males take, to reduce or attenuate, I guess, hair loss,
right,
male pattern baldness, and that knocks down DHT, right?
Correct.
So what's the effect that a compound like that would have on testosterone, if any, or strength?
Yeah, this is a really widely debated topic in the community. So the way that it works real quick is testosterone can go two ways. It can be aromatized into estradiol or estrogen, or it can be 5-alpha reduced into DHT, dihydrotestosterone, which we're talking about here. The enzyme that makes testosterone converted into DHT is called 5-alpha reductase. Finasteride or dutasteride are 5-alpha reductase inhibitors, so they inhibit that enzyme to turn testosterone into DHT. Now, doing that, as you mentioned, may have some side effects like lowering strength. It could potentially lower libido, could lower sperm count or change the quality of the sperm. It could lead to mood issues. The other issue with the medication is that 5-alpha reductase doesn't only convert testosterone into DHT, it also converts other neurosteroids like progesterone into allopregnenolone. So there's some thought that the depression or depressive-like symptoms of finasteride may come through the neurosteroid cascades that it impacts. Now, it's really debated, as I said, because the literature would tell you that only around 2% of people who use finasteride experience those side effects. Now, clinicians who see these guys all the time would argue it's probably much higher. I know Peter Attia recently has had 2 prominent urologists on, both of which said that they would never touch the stuff.
Is that potentially a selection bias, though?
100%. I was going to say, yes. See, I have a large bias towards it because whenever guys come to me, they're not coming to me saying, hey, I just wanted to schedule an appointment and tell you I'm doing really good on finasteride.
Exactly.
They're coming saying I have post-finasteride syndrome is what it's called, or PFS.
Oh, that's what it's called?
Yeah. Okay. So, if you search post-finasteride syndrome on Reddit, thousands, if not millions of threads about guys saying that they're suffering with this.
Which is like depression or affecting sexual function.
Correct. Yeah, usually lack of libido, poor erection quality, depression. There's even suicide linked with it too. It's just hard to say. Where it gets a little interesting for me is that the company that made the drug settled out of court saying that they agree that they left out a lot of these side effects when they published their data.
The drug was originally made for prostate cancer, right?
Either prostate or hair. Yeah, probably prostate first and then hair.
Right.
Yeah.
Okay.
Yeah.
Yeah, because the very little reading I did, I think that was like a 5 milligram dose or something.
Yeah, it's a very low. Also, the dose that they give is very high. It has a very long half-life, so you don't need to give that really long or that really big dose. You can give much smaller. So a lot of people, instead of like a 1 milligram daily of finasteride, sometimes they do a 1/4 milligram daily and they feel a lot better. So I don't know. There's a lot of debate there. I personally don't want to risk it. I mean, I just shaved off all my hair because I'm like, I'm just going to, embrace it. Maybe I'll get a hair transplant. I don't know. But it just kind of scares me to take the most potent androgen, because that's what DHT is. It's the most potent androgen our body has, and just to reduce it. Though I have a lot of people that I'm close with that say they take it and have no effect and don't feel anything. Another very interesting thing that occurs, though, is that through the androgen receptor mediated effects, sometimes that takes years to show, to like get to its final effect. And a good example of that would be puberty. You know, a lot of boys probably start puberty around 13. Sometimes a guy doesn't have a beard until they're 19, maybe later. It takes you a long time, and you're still exposed to the same amount of androgens, but it can take years for that to manifest. And sometimes guys go on finasteride, and 2 years in, the side effects come, but they go, well, for the past 2 years, I've been fine, so it can't be this. It's got to be something else. I wonder, is it being mediated through the androgen receptor and just took a long time to exhibit its effects?
So what would your advice be to someone who, and I asked this because I think I shared a bit of a post and I got a number of questions. And someone did say, you know, I'm taking finasteride, I don't have side effects. Is there a potential problem for that person to continue taking it?
Hopefully not. I mean, I would tell them good, great. It's hard, you know, because I'm afraid that I would probably, you know, have a placebo or a nocebo, you know, where I would be like, I've seen so many people have it. I would be afraid and I would probably, you know, freak myself out. But if you're not having if you're not having any negative effects, you're feeling great, cool, stay on it, you know? I don't know. It's hard to say.
How does the body make testosterone? I know you said most of it's made in the testes.
Correct.
But I think understanding that process, at least at a high level, might be helpful when we talk later about cholesterol levels and the synthesis of testosterone. Yeah,
very important. So it kind of starts in the brain, actually, in the control center, which we all know, the hypothalamus. So the hypothalamus will send a signal called gonadotropin releasing hormone to the pituitary. The pituitary then secretes luteinizing hormone, or LH, or follicle stimulating hormone, FSH. Those two are signaling hormones that go down to the testes and either bind to LH or FSH receptors on Sertoli or Leydig cells and produce both sperm and testosterone. That testosterone is synthesized through cholesterol, from cholesterol to pregnenolone to testosterone downstream. So yeah, the question, you know, comes as how cholesterol plays a role in that.
Right, because you know, I think something you see online quite a bit is, you know, if you, we're skipping ahead a bit, but we're going to jump around, is, you know, cholesterol is important for the synthesis of testosterone, which is true, right?
Yeah.
Then people kind of make the leap that therefore anything that lowers your cholesterol, be it a diet swap, diet change, or a pharmaceutical compound that lowers cholesterol, serum cholesterol right. in the blood, must be deleterious for testosterone production.
Yeah, it would make sense if you're looking at it like mechanistically, you would say, oh, if there's less of this cholesterol, then there will be less ability to make the testosterone, until you realize that every cell in the body can make testosterone as needed. So the level of cholesterol that we see in our blood and serum cholesterol is a small fraction of the total body's cholesterol. Every cell has cholesterol in it. It can make its own when it needs it. So we actually have really good data, since we were able to make these PCSK9 inhibitors, which can basically just reduce your cholesterol to virtually zero. And then we can see what kind of effects they have on hormones. There's one in particular, I think it was out of one of the Asian countries. I forget. I think I sent you the link. But
Evo, was it Evo something?
Could have been, yeah. But they took the PCSK9 inhibitor. I think they dropped the LDL cholesterol down to like 7. So
it's crazy low.
For people listening, like in the US, you know, usually a cholesterol above 70 to like 110 is deemed kind of normal, and higher than that is bad. So yes, 70 is kind of normal. You know, they dropped this all the way down to 7.
Which no one is going to get down to that level just through lifestyle changes.
Right. Yeah, unless you have some genetic anomaly. But they didn't see any impact on sex hormones. So none of the neurosteroids above testosterone, like DHEA or pregnenolone, they didn't see a reduction in testosterone or estradiol. So we can what we can glean from that is that you can lower your cholesterol significantly, and you're not going to impact your serum level of testosterone.
Yeah. So just to kind of reiterate that to folks, when you were saying that drug knocked cholesterol down to 7 milligrams per deciliter, that's what's circulating in the blood.
Correct.
It's not knocking the cholesterol down in the cells through the body.
Correct. Which
are producing cholesterol, and that is being used to help synthesize testosterone, at least in the cells in the testes
or adrenals. Yeah, and that's something to think about with all cholesterol-lowering medications or all cholesterol arguments. Whenever somebody tells you that you don't want to lower your cholesterol for X, Y, and Z, that just isn't the case, because we're simply talking about serum cholesterol.
Different compartments.
Yes.
Talk to me a little bit about the difference between total testosterone and free testosterone?
Yeah. So after your testes get that signal, they produce the testosterone. Testosterone is a hormone. It's you can look at it as being like a lipid. It's fat soluble, so it doesn't mix well with water. Everybody's tried to mix oil into water, and our blood is this aqueous source, so it's kind of a water based. We need a carrier protein to carry it around, and our body produces something called sex hormone binding globulin, or SHBG. Usually, most of our testosterone is bound to SHBG. Some of it is bound to other carrier proteins like albumin. And SHBG is basically, you can kind of look at it as like a bus. It's a transport protein, takes your hormone from one area of the body and brings it to another. It also helps to regulate. So we don't want too much free testosterone, because then we would kind of be sympathetically overdriven. If we just have all of these high levels of testosterone and nothing to regulate or put a brake on it, we're going to have a too much signal. So SHBG is super complex. And this is something that I don't fully understand. I don't think anybody does. I've spent so much time in the literature trying to look at SHBG, but the message that's usually kind of touted or kind of reported is that you want your SHBG kind of as low as possible, and you want your free testosterone as high as possible.
Because if SHBG is high, it's binding up a lot of that testosterone.
Correct.
And then it's not free to actually have actions Correct. Through the body.
100%. My pushback to that would be, the healthier you get an individual, the higher their SHBG goes. So
that's counterintuitive.
Right. Yeah. Why would a healthy individual have no testosterone unless, we're meant to have low levels of testosterone? It just doesn't make sense. But
don't women have higher SHBG than
they
men?
Can. Yeah, they can. Yeah.
Okay.
And SHBG does bind up estradiol too, but it binds to DHT with a higher affinity than testosterone, higher affinity than estradiol.
So it's kind of like how ApoB is chaperoning triglycerides and cholesterol through the blood.
Yep,
Again,
exactly.
they're not water soluble.
Yeah.
This is the same sort of thing. Testosterone needs to be shuttled.
Yep.
It's SHGB that's doing that.
Yeah, some testosterone rides along on lipoproteins like that too, so small amount of it. But yeah, any of these proteins that a hormone or a lipid can bind to and get through. But yeah, it's very interesting that the healthier you are, the higher SHBG is. Kind of counterintuitive, like you said, doesn't really make a lot of sense. If you look at, say, a type 2 diabetic or somebody with metabolic syndrome, somebody has high amounts of inflammation, high amounts of insulin, they have very low SHBG. SHBG is suppressed by insulin and high inflammation. So my pushback would be, I kind of look at SHBG and this whole free testosterone hypothesis to almost be like propagated by the TRT clinics. When somebody comes in with, say, a good total and then they have a low, they can say, well, your free is low. I think you need this TRT. And sometimes it is the case. But I'm going to contradict myself a lot throughout this whole process of talking about testosterone, because there's so many nuances. Sometimes guys do have very high SHBG, very low free testosterone, and they don't feel great and they have symptoms. But a lot of times they don't. And symptoms are hands down the most important thing to think about when we're talking about testosterone. I'll repeat that the whole time.
Yeah, I don't think you're necessarily contradicting yourself. I can see how it may seem contradictory to the listener, but what I'm hearing from you is that the context matters.
Yes. Yeah. There's a lot of nuance, because when we talk about testosterone, why I don't like to even focus on really numbers or anything is because everybody is a genetic individual that has genetic differences.
But Adam, we love numbers.
I know, we do. It's so hard.
I want a target.
It's really hard too for doctors don't really understand it too. And we talk about the reference ranges. I've seen guys who have like a 200 testosterone. I mean, I've seen, prominent
200 total testosterone.
Yeah, 200 total.
And that's in
low.
like nanograms.
Nanograms per deciliter.
Per deciliter.
So extremely low. And these are guys who a lot of people know and look up to as being like just beasts, like professional athletes, influencers. And they tell me the truth, what they've done in the past, what they're doing now. And they'll be like, my testosterone's always been low, but I just always grow muscle. I feel good. Everybody thinks I'm on steroids. I swear I'm not. And, they don't have any reason to lie to me. And I've seen it time and time again. Conversely, though, sometimes a guy comes in with like a 500 and every symptom under the book, and he's doing everything else right. He's getting good sleep, nutrition, his mental health is good, everything is good, but he feels awful. And you give him some testosterone and increase that, and he feels better. So it's all about symptoms, and it's all over the book. It's all over the place.
Yeah, I want to put a pin in SHBG and come back to it, because I showed you some of my lab results and I made some tweaks on supplements, and BG went up.
Yeah.
It went up a little bit. and the least the lab report I got suggested that wasn't great.
Right.
But total testosterone went up as well. So let's come back to that. But what do you think about the idea that your free test should be about 2% of your total test?
Yeah, I think that's fair. It's kind of an average that we see. It's usually kind of where it falls, two plus, like to 3. We don't want it too low because then you don't have that testosterone available to have its effect. You also don't want it too high because, as I said, when you have your free testosterone too high, guys get very sympathetically driven. So they get that fight or flight. And this is something I see all the time. Guys always think more testosterone, the better. But if you actually talk to a lot of the bodybuilders, when they're at their peak, their highest doses, they don't feel good. You feel awful because you feel that fight or flight all the time. So you kind of, like when testosterone or most things, it's kind of this curvilinear, graph where if it's too low, you don't feel good. And if it's too high, you don't feel good. And a lot of the side effects fall within that too. But guys will come in with, lack of poor erection quality, low libido, and their levels are high. And I'm like, let's bring it down. And that doesn't make sense to them. They're like, no, more is better. But I try to tell people sex is a mixture of both parasympathetic and sympathetic nervous system, right? You need to be relaxed in order to have sex. You're so sympathetically driven right now. Your mind thinks you're running from a saber-toothed tiger or something, because you're always on. And so it's hard for you to get an erection because your body's in fight or flight. It's not in reproduce mode. So that happens a lot too with too high of free testosterone.
What happens to estrogen if you have really high testosterone?
It will go up too because the testosterone is then being aromatized into estrogen if you have a lot of aromatase.
And can that be part of that explanation as to why libido could be affected?
It could be, but actually estrogen is something that I think kind of got inappropriately demonized for a long time. And now we find that estrogen has a plethora of benefits. It's actually a really good paper in the New England Journal of Medicine. And their conclusion to the results that they did was that TRT, the benefits of TRT are actually via increasing estrogen, not the testosterone. Because they took guys and they put them on aromatase inhibitors or selective estrogen receptor modulators, SERMs, and they blocked the effects of estrogen and all the symptoms came back. And for years, guys, by endocrinology standards, are put immediately on an anti-estrogen drug when they're initiated TRT. And we find that when we take those out, symptom relief occurs. I believe that most of the benefits of testosterone, when you hear cardiovascular, neurological, that's all coming through estrogen. So we don't want to just arbitrarily lower estrogen to some certain number.
That's going to be news to some people.
Oh, absolutely.
I think a lot of people assume that estrogen is the female sex hormone.
Right. Yeah. In that study, the guys who had lower estrogen had more adiposity, they had more body fat, and they had less libido and poor erection quality. So the more the estrogen went up, they got leaner, they got better erections, they had better libido.
There you go. How were you said you don't really like numbers, but let's just think about the current reference ranges for total testosterone and for free testosterone. Were they developed based on building strength, on libido? Yeah. How do we come to those numbers?
Yeah, this is a really good discussion. Again, now I'm going to kind of counter myself because I think that the numbers that we have are terrible. I'll say why, because we first had these ranges kind of around 2011, I think it was, and they took a data set of 4 studies. It was the Framingham Heart study that you know of. There was 2 osteoporosis studies, and there was European aging male study. So it was 9,000 kind of participants. I think they took 100 people from each group. And they came out with these reference ranges in 2011, and I'm going to go based off nanogram per deciliter. It was 350 nanograms per deciliter all the way up to 1,200. In 2017, they took that same data set and then they did this really complex statistical analysis on it. They called it harmonizing, where they harmonized all of these groups and they changed the reference ranges and they dropped it to the left. So everything went down. So now the ranges are 264 nanograms per deciliter up to 916. So if in 2011 you had a testosterone of 300, you were hypogonadal and you were treated. In 2017, you're no longer hypogonadal. Here's an SSRI. All of your symptoms are in your head. Get lost. You don't have low testosterone. So now a lot of guys have just been, kind of mistreated, I think, because we changed the reference ranges so dramatically. we know that testosterone is dropping decade after decade. Our testosterone levels are lower than our father's testosterone is lower than his father's. And we're making the reference ranges kind of, illustrate that, which doesn't make sense to me.
Our testosterone levels are lower than our father's. His were lower than his father's.
Correct.
At the same age.
Correct.
So when they were, 35 or 37 or whatever it is,
right,
they had higher testosterone levels.
Yes.
So we're seeing that as a trend, this downward trend of testosterone declining. Why?
Testosterone and fertility. So there's a lot of debate there. I don't have the answer. My guess would probably be environmental exposures. I think, the endocrine disrupting particles, microplastics, exactly. Things that our ancestors, or hate that word, but, people before us weren't really exposed to the extent that we are. But also, excess adiposity, high amounts of inflammation, all of these things contribute.
Right. Maybe poor mental health and stress.
Absolutely. We don't, also I like more on, just a kind of hypothesizing, we don't have a hard life really anymore. Why do we need high levels of testosterone to get us through it? So things are so easy. And I don't know that like evolutionarily it's been long enough to make a change like that, but there's so many things that contribute.
So what would you like to see that range as? Just go back to that 350 to 1200 as a normal range?
Well, my biggest issue with the way that they did the harmonization of that is that they based it off of what they deemed healthy. So their inclusion criteria or exclusion criteria was that they basically went off BMI. And so they said non-obese males without a disease like diabetes. I didn't see them mention pre-diabetes. They weren't testing things like fasting insulin. They weren't testing things like CRP. It was just, were you non-obese on BMI? And there's a really interesting study, I think it was in 2023 in the Frontiers of Nutrition, where they took DEXA with BMI, and they looked at people who had a normal BMI that was below 30, below obese, and around 70% of the men in there had excess adiposity, meaning obese adiposity, so greater than 25% body fat, which is what bariatric surgeons.
But they were considered normal.
They would be considered normal.
Right, so that comes down to body composition.
Correct. Yeah. And so if you're taking a study and you're looking at the, levels of testosterone in what you call healthy men, but your men aren't actually healthy, they may be highly inflamed. They may have this excess adiposity. They may be pre-diabetic.
Under-muscled.
Yeah. Are these people actually healthy young males? I would argue not. We don't have a study with a good group of men who are like, probably 15 and lower percent body fat, who have their fasting insulin checked, who have their CRP checked. It's very similar to like ApoB, for example. When you're looking at it, somebody like you who cares about this, who looks at the literature, probably knows that it's better to have your ApoB probably below 60. To really be ideal, but the reference ranges say 90. And if you go into your doc and you say, hey, mine's 90, they're going to say you're good, So it's very similar to testosterone. The reference ranges probably aren't ideal for optimal health. And that's my biggest pushback on it.
Surprised there hasn't been a study on, I don't know, folks in the army, males in the army or something.
Yeah, that would be good.
That'd be a good cohort.
Yeah. It'd just be hard because you would need a DEXA scan, which would be extremely expensive. If you DEXA'd like 5,000 people, and then you were also looking at those more in-depth lab markers like the fasting insulin, CRP, I think it would be a tough study, but we need one. I think if we're going off of this T score that says the range of healthy young men.
Well, the TRT clinics are surely making enough money to fund that.
That's true. That's true.
You've mentioned some of the symptoms, but let's just kind of underscore this. What are the most common symptoms that someone might be experiencing if they have low testosterone? And are there any? You mentioned before that a lot of these symptoms there are kind of a slew of things that could cause those. Are there any that are a little more clearly indicative of low testosterone?
Unfortunately not. I wish, because I would say like libido and erection quality are probably some of the ones that most people would assume. But, libido, that's so psychological, probably more than anything. Erection quality, I would argue having ED in this country is more associated with atherosclerosis than it is hormones. So
it's one of the first, I think, reasons why a lot of men with cardiovascular disease go to see their doctor.
Absolutely. But most people, nobody wants to hear it's your cholesterol. They want to hear it's your testosterone. Give me a shot. But yeah, we're talking, libido, poor erection quality, being fatigued, putting on body fat, having a hard time putting on muscle, lower, like poor mood, brain fog. But I'm sure you could have just listed off 5 things for each of those that it could also be. So it's very hard. Unfortunately, there's not one thing that it's like, oh, this is 100% testosterone.
Right. So it's this combination of understanding where your testosterone level is currently at, total and free. How are you feeling? The combination of those two things. Are there any other hormones that someone would be testing at the same time to get a kind of better understanding as to, whether the experience, how they're feeling subjectively is a kind of sex hormone issue and they should pursue some type of hormone optimization?
Yeah, I mean, if they're doing their due diligence, which is another thing, oftentimes they'll just pull the testosterone, and that's not ideal in my opinion. We have other things like thyroid. Prolactin is a big one. A lot of people have probably never had their prolactin tested. High prolactin feels a lot like low testosterone. So the symptoms of high prolactin are low libido, poor erection quality, delayed orgasm, low motivation. Prolactin is our like direct kind of suppressor of dopamine. So when a man has an orgasm, I think every man has experienced this, when right afterwards, suddenly you lose all libido, everything just turns off. You're like, whoa, okay. You just want to be left alone. That's mediated via prolactin. So some guys have elevated prolactin for multiple different reasons. Drugs like SSRIs can cause it. There's some thought that foods like dairy can cause elevations of prolactin. Marijuana, THC can cause elevations of prolactin. A lot of guys have a high level of prolactin, which is suppressing dopamine, and they're inappropriately thinking it's their testosterone when it's their prolactin. Conversely, if you have a low thyroid, you have high levels of TSH and you have high levels of thyrotropin releasing hormone, which also stimulate prolactin. So sometimes it's a thyroid issue and you have low energy because of thyroid, you have low libido because the thyroid stimulating prolactin. So all of these hormones are so complex that it's a lot more than, spitting a saliva test of testosterone, sending it off to a clinic and they send you, a TRT script.
Mm-hmm. You mentioned hypogonadism
before. Low testosterone.
Right, low testosterone. I've seen people talking about primary and secondary.
Yeah.
What are the differences between those, and when might someone order lab tests looking at, I think, LH and FSH, those two hormones you mentioned before, which are produced by the pituitary gland. They stimulate these cells in the testes to produce sperm and to produce testosterone. So big question there, but what's the difference between primary and secondary hypogonadism, and when, if at all, would you test LH and FSH?
I think you always should if you're looking at testosterone, because you definitely want the whole picture. So to break down or to separate primary from secondary is there's an issue in the testes. So the signal is there. The LH and FSH are there. They're sending the signal. The testy isn't responding. So something is wrong with the testy and the testicular cells. So that's primary hypogonadism. Secondary would be there's an issue in the either hypothalamus or pituitary. Your LH and FSH are suppressed and you're not producing the testosterone. So then you could get your testosterone up by another signaling molecule, potentially.
Mm-hmm. Right. So out of the two of those, is secondary easier to treat than primary?
Yeah, because you can at least stimulate the testes to keep producing sperm or testosterone, but you can't, if your testes won't make testosterone, they just won't make testosterone,
Got you. And what kind of compounds would kind of act as LH and FSH or stimulate the production of those?
So that's a good differentiation. We either have ones that act or mimic, which would be HCG is the main one, human chorionic gonadotropin, hormone produced mainly in pregnant females. Very small micro amount is produced in men as well, but that in men mainly acts as an LH mimetic or a mimic. So it mimics LH, it binds to LH receptors and stimulates Leydig cells to produce testosterone. Or you have other drugs like SERM, selective estrogen receptor modulators, which work to bind to estrogen receptors in the hypothalamus and pituitary and it kind of suppresses the feedback loop. So we should talk about how our brain senses it needs to produce testosterone, which is mainly through estrogen. To go back to my argument of how important estrogen is, our brain doesn't really care where the levels of testosterone is, but if estrogen gets too low, that's when we start producing testosterone. So our brain is sensing via the estrogen receptor for levels of estrogen in the hypothalamus and pituitary. When our estrogen is too low, that's when the hypothalamus and pituitary start producing LH and FSH. So drugs like SERMs block the estrogen receptor up here in the brain, kind of trick your brain into thinking estrogen's very low, and they flip the switches of testosterone production on. So LH and FSH start being produced.
So is that Clomid? Is that one of those?
Clomid, yeah.
It's like
Clomid.
Popular. I've been on Reddit before this, and all this stuff's half my questions are from Reddit, guys.
Yeah, Clomid is the original, like one that people use nowadays. We use enclomiphene a lot more.
Okay.
So Clomid is a combination of enclomiphene and zooclomiphene. The zooclomiphene aspect is anti-androgenic of sorts, so it can cause some lower testosterone symptoms. It also is associated with a lot more of the side effects. So we've kind of synthesized out this enclomiphene. People use that a lot more because it's mainly just driving up testosterone.
So when you go, like if you have low testosterone and you present as someone with low testosterone, low libido, low energy, you run your tests, testosterone's low. Do clinics offer like some of these compounds? Like is there a scenario where someone takes a compound like HCG to essentially get the body, what I'm hearing, to produce its own testosterone?
Yeah.
To get you into a normal range versus adding exogenous testosterone?
They do, yeah. And actually, I think those compounds are more expensive than testosterone. So sometimes they may offer that first, and maybe it's more a moneymaker. But they do. And a lot of guys, especially younger guys, usually sub 30, who still care about fertility, that don't want suppression, they're going to opt for more of one of those, either HCG or a SERM or a combination of the both, to try to preserve or stimulate testicular function.
Okay, so talk to me about that. So it's as soon as you introduce an exogenous for testosterone, that shuts down that system essentially, because is it the pituitary gland or the hypothalamus? Hypothalamus is saying, hey, there's already enough of this sex hormone around. We don't need to send these signals down, and therefore you don't get the signal for testosterone production in the testes, but also sperm production.
Yes. And so you don't get LH for testosterone, you don't get FSH for sperm, but also testosterone production is vital for sperm production. So even if you had FSH, but you don't have LH to stimulate testosterone production, the intratesticular testosterone production is one of the cascades responsible for producing sperm. So when you produce sperm, FSH binds the FSH receptor, Sertoli cell starts the sperm, and testicular testosterone also helps with that sperm production. So you need to be producing sperm in order to produce, or testosterone in order to produce sperm.
It's interesting. Do you think, I mean, I would presume if you go to a clinic and they give you HRT, they talk to you about the effects on fertility. Like, does it make you infertile if you're taking a HRT dose, getting your testosterone into normal range, you're 30 years old? Are you completely infertile?
It's a tough one. Got a friend who says, what do you call a guy on TRT who uses a birth control? A dad, because it's not always 100%. So it's about 60% in the literature is what it says. About 60% of men on TRT will become infertile. That's a big risk for a lot of guys, but like building a family is a really big, important thing. So 60% possibility.
Is that reversible though?
Sometimes. It's all over a lot of time. I would say most of the time it probably is, especially given it. I kind of personally hypothesize it has more to do with the time on. So if a guy goes on TRT for, let's say, 6 months and decides to come off, that's probably pretty easy to reverse. Conversely, if a guy goes on for 6 years and their testes haven't been functioning for 6 years, they've kind of atrophied, they've fibrosed because they're not being used, kind of just a vestige of an old organ. So it can be very hard to stimulate those and get those back. So I kind of think that the time on versus time off, and it's usually more the testy issue. Luckily, the pituitary is secreting so many other hormones that's not really atrophying or having an issue. So getting your LH and FSH back is usually not tough, but getting the testes to produce sperm and testosterone is usually harder.
Okay, so let's consider an avatar here. 30-year-old male. He is interested in having kids, so he would like to keep his fertility, ideally. But he has low testosterone. Let's say it's just a little bit low, maybe 280, 260. That was like the bottom end of that.
That's pretty low.
Right, pretty low. So it's 260 nanograms per deciliter. Mm-hmm. Wants to stay fertile. What I'm hearing from you is if he was to just go and use exogenous testosterone, whether that's bought on the streets in the gym or at a HRT clinic, he runs the risk of shutting down his own production of sperm.
Correct.
And testosterone.
Yes.
And I think you said that happens to about 60% of people that do that, even if he's not using crazy amounts.
Right.
Okay. So what are his options? We're going to get to lifestyle. So maybe there's some lifestyle changes.
Absolutely.
Is HCG an option? Is taking exogenous testosterone, but with something else that keeps him fertile? Like, what are the things that someone like that should be thinking about?
Yeah. First and foremost, I would always say lifestyle. We'll get back to that. We should focus a lot on that because that should always come first. Next, then you can have the discussion of, do you want to try HCG monotherapy, so HCG alone to just stimulate the production? Do you want to try a SERM, a selective estrogen receptor modulator, and stimulate the pituitary to produce LH and FSH? Do you want to try a combo of those? Some people do that. That's just kind of going overboard, in my opinion. Or do you want to go on TRT and add HCG in hopes that we continue to produce testosterone and sperm while on? There's some data that says being on HCG is fine, and it was 100% of guys maintain fertility, but we don't always see that in practice. When you actually when I've seen a lot of guys, close friends of mine, be on TRT with HCG and still have a 0 sperm count. So that's an issue. But I'll always tell that guy, first and foremost, the most important thing you should probably do before ever going down that road, get your sperm analyzed first. Because just like testosterone is declining, sperm counts are declining too. And I think a lot of guys have low sperm count beforehand. And if they have low testosterone, they probably have low sperm count because they go hand in hand, as we talked about. So they may actually have infertility to begin with. They go on TRT, they try to get off. Now they're blaming the TRT and the doctor for their infertility that they always had, but they never tested. You can also have your sperm frozen, which is a process. I understand it's very difficult on the female to do all of that, but it is something that, if a guy's very symptomatic, absolutely needs TRT, and he still wants to have a family and he's fertile,
you can bank it.
Probably a good option to bank it. I think that's important. I kind of recommend most guys do it anyways, because I've seen some traumatic injuries on pedal bicycles where they fall and hurt their testy and now they're infertile. So probably not a bad idea to do since we have the technology. And if you've done that, if you've frozen, then you always have that in the bank, as you said. So those are kind of your options. You can go HCG alone, a SERM alone, or TRT with HCG. Now, some clinics will use these newer compounds like ganatorelin. And the idea there is to stimulate the release of LH and FSH. They don't really work. I'll say that right now. If your clinic is giving you something like ganatorelin, I would go elsewhere because they're just taking your money, and they should know. If they don't know that it's ineffective, then you get another practitioner. And if they know and they're still giving it to you, then they're, unethical. The ganatorelin is a substance that was used in studies as a pump. So somebody has a pump in their body and it's releasing it all day long, and then the LH and FSH are stimulated. These clinics are selling it for probably $1,000 a pop, and they're doing 1 injection of a week. It's never been shown to work in 1 injection or 2 injections or 3 injections. It's been shown to work as a continuous pump, and you don't see LH and FSH increase. And guys are putting out all this money thinking that they're preserving their fertility, and they're not. So if you're going on TRT, the one and only thing that seems to work is HCG.
HCG. And I appreciate this. This is probably context dependent, but I think you mentioned before the typical dose of HRT is 100 to 150 milligrams per week.
It varies. So I've seen guys on as low as 70 milligrams a week. I've seen guys upwards of 200. I would say 100 is kind of like the endocrinology standards where they start most people. Historically, I kind of really disagree with the historic endocrinology ways of giving TRT too. They usually give 1 dose either once a week or sometimes every 2 weeks. Just mind-boggling when you think about the pharmacokinetics of the drug. So it has a half-life around 7 days. So at day 7, half of it is gone. And so what they're doing is they're shooting these guys' levels up, and then they're crashing. You talk to these guys that are on the standard treatments, and usually, they do their injection Monday. By Sunday, they're dragging. They have all their symptoms back. They can't wait till
roller
Monday.
Coaster.
Yeah. So what a lot of newer practitioners have adopted is more frequent micro injections to keep levels a lot more stable. The body.
What's a micro? So if someone was on, let's say 100 milligrams a week, you're breaking that down into 20?
3. Yeah. So yeah, what like standard, a lot of times people do 120 milligrams a week and they break that up into 340s. So like Monday, Wednesday, Friday, Tuesday, Thursday, Saturday, kind of like in every other day. Since it's 7 days, we don't always get equal. But yeah, if you can do it more frequently, then the idea there is that the levels stay a lot more stable. What also used to happen a lot with that old way of dosing is we'd start getting all these estrogenic side effects. And that's where we start thinking estrogen is this bad guy, because guys can have estrogenic side effects. Like the main ones would be around breast tissue, so gynecomastia, breast growth. So when you're spiking testosterone, you're also spiking estrogen because it's aromatizing. Your estrogen stays high, testosterone drops, and now you have this messed up ratio of very high estrogen to lower testosterone, and guys start having symptomatic, estrogen side effects. So a lot of guys can get rid of all of those if they just do more frequent injections, keep their levels a lot more stable as we would naturally, because naturally we would produce a little bit every morning. So our levels just kind of go like this. They're never doing these huge spikes and drops.
Right. I have so many questions.
Awesome.
Allow me to introduce you to Momentous, my go-to supplement brand for all things protein and creatine. It's pretty easy, especially if you're not tracking everything that you eat, to fall short of the optimal daily protein intake. To help reach my daily protein target, I complement my diet with 1.5 scoops of Momentous's chocolate or vanilla chai plant-based protein for 30 grams of protein and all essential amino acids, which supports muscle growth, hormone and collagen production, skin health, and recovery. I also consume 10 grams of Momentous's creatine daily to enhance energy production, muscle strength, bone health, and cognition, with studies now showing the benefit of creatine on short-term memory and intelligence. I'll do anything for a little extra brain power. And what's really cool is that both products are NSF certified. This certification is the only third-party certification program trusted by the likes of the NBA, the MLB, Ironman, etc. With this, you can be confident that Momentous's protein and creatine are free from unsafe levels of contaminants, prohibited substances, or masking agents, and that what is on the label actually matches what is in the product. For discounts on these supplements, visit livemomentous.com and use code LIVINGPROOF for up to 36% off on subscriptions or 20% off one-time purchases. That's livemomentous.com with code LIVINGPROOF at checkout.
Let's start with back to this avatar. This person chooses to go down the route of TRT but using HCG at the same time. And so my understanding is that what's happening there is their testosterone levels are going to go up in their blood, but HCG is stimulating the production of LH and FSH, hopefully.
No, it's mimicking LH.
Mimicking.
Yeah.
Sorry.
So that's one thing that some people do. That's a frequent misconception.
Okay. Sorry. So it's mimicking LH,
Just
which
LH.
is stimulating. What are the name of those cells in the testes again?
So Leydig cells produce testosterone, Sertoli cells produce sperm.
Okay. So what type of dose or how would someone take HCG?
That varies, usually somewhere around 200, 250 units is what it comes in 3 times a week or so. Sometimes they'll go up, but you got to remember too, since you're stimulating the testes and those Leydig cells, that will also increase testosterone. So sometimes the total testosterone dose is lower when you're on HCG because it's all adding to that overall pool. Another thing with HCG is that it's not completely innocuous. So it's not benign. Some people get symptoms from that, and
what are they?
I mean, they can be very similar to estrogenic side effects. There's some thought that it aromatizes, that it drives more aromatase expression. I've kind of looked into this a lot, and we find LH receptors in breast tissue. So if you're stimulating these breast tissue LH receptors, you may be getting gyno from it, or gynecomastia, breast tissue growth. Some guys will get just mood disturbances. And I mean, you're putting a female pregnancy drug into a man and hoping for the best. And it does mimic LH, and most people are good, but some guys get told they're crazy when they don't feel good. And I'm like, we just might not know enough about this compound yet. Putting this female pregnancy drug in a man might not be completely benign. So there's arguments to, if you don't feel good on it, maybe you don't. But the really weird thing, it's very similar to finasteride. Like some guys feel better on HCG, some guys feel worse on HCG, some guys feel nothing from HCG. So it's so hard to give your patient, an accurate representation of what exactly will happen to them. You just have to educate them and give them the,
right. It becomes a game of chess. You're moving one thing around, and then that might have some side effects. So you have to take that compound and that
100% is. And that's why, I personally don't think that endocrinology has done guys a good service, unfortunately. I think they're great at a lot of things that they do. But when you just give testosterone and an AI and everybody gets the same dose, same dosing protocol, and you just send them out the door, that's not okay. That's how a lot of the TRT clinics are too. They just have these cookie cutter programs where we give everybody 150 and they get an AI and they get HCG and they get ganadarelin or whatever, and they get pushed out the door. Like I said, I've seen guys from 70 to 200 in their doses. I've seen guys on HCG, not on HCG. Like everybody is an individual, and you really need somebody who understands the nuances of this stuff. Not your bro at the gym, not the TRT clinic who's just trying to make a buck. It's really big stuff.
What about the bro at the gym who they weren't able to listen to a podcast like this 15 years ago.
Right.
And so they were using high doses of exogenous testosterone without any other compounds. So you made it clear earlier that might shut down their production of sperm and lead to like atrophy of their testes. Let's say now they're further down the road and they want to have kids. Can they come off of that exogenous testosterone or stay on it, but add HCG? And is that enough to kind of activate, wake up this sleepy organ enough so that it kind of learns and remembers what it needs to do?
It can be. And another thing I said, bodybuilders are an awesome sample size to look at. And we look at bodybuilders. I mean, Chris Bumstead's wife, Courtney, is pregnant right now. He's obviously very open with his use. Ronnie Coleman, I mean, you probably have ran into one of his kids because he's got like hundreds. Like Ronnie Coleman has a lot of children, and he obviously was on steroids. A lot of bodybuilders have children. So they're doing it to, the 10th degree, like super high, and they're still having children. So it is possible. That's why, when I say it's all over the place, some guys do struggle with long-term infertility, but did they get their fertility checked beforehand? Because maybe it was always an issue. And maybe if you're fertile to begin with, it's not that hard to come back. It's really hard, very nuanced, very individual dependent.
You mentioned earlier that dose of HRT could be, was it 70 up to 200, something like that, milligrams per deciliter? Just milligrams, sorry. I'm thinking about ApoB.
Yeah.
If someone, let's say they are listening and they've tested their total testosterone and they're at 350, let's say, but they feel pretty good, but then been hearing about TRT, their buddies have jumped on it, and they think maybe I should jump on and take a dose and take my 350 up to 700. That's probably something that you get asked a lot.
Happens every day.
Right.
Yeah.
So what's your advice for that person? Like, what are you thinking about here?
Yeah, it's tough because I tell them, do you feel good? You don't have any of the symptoms. Why would you want to do this? And remember that TRT is just supposed to make you normal. Like, it's not going to give you these Arnold Schwarzenegger style gains. And I also remind them that everybody's different. We have really individual differences, mainly probably in the androgen receptor. So we talked about earlier, or maybe we didn't, testosterone, in order to work, needs to bind to a receptor. All hormones are this way. So you have your receptor and you have your ligand. Testosterone in this case is the ligand. It is the hormone. So it binds to that receptor, and the hormone does not work until it's bound. So if you have, that's the point of the free testosterone, is since it's not binding to a receptor, it's inert essentially. So after you've bound to that receptor, you can exert all the benefits of testosterone. But we have individual differences in the amount of androgen receptors that we have first. So some people have more androgen receptors than others. And men, a lot of our androgen receptors are in our upper body. It's kind of a way that we kind of differentiate natty or not. Sometimes you can look at fake natties and they've got huge delts, huge traps, and their legs are all skinny. There was a prominent carnivore guy who kind of fit that phenotype of very jacked upper red traps and everything. And then his legs are kind of skinny. And it's like, oh yeah, he's probably on androgens. But
we won't name him. I think he had King in his name.
Yeah, something like that. Yeah. One of the Johnsons, I don't know. But yeah, so the androgen receptor is where all the effects come. And we have genetic differences in there. And also we're finding more and more of the sensitivity to the androgen. So we have these polynucleotides, and it's really complex in the biochemistry and genetics, but there's these things called CAG or CAG repeats that are associated with androgen receptors. And the more of these CAG repeats you have, the less sensitive your androgen receptor is to testosterone. So there's a disease called Kennedy's disease, or I think they call it spinal bulbar muscular atrophy these days. I learned it as Kennedy's disease. But these people are very insensitive to androgens. They have low amounts of muscle, so they need more testosterone to exert the same effect. Conversely, the Ronnie Colemans, Chris Bumsteads of the world probably have very small amount of CAG repeats, and they are very sensitive.
Right. So if you have two people who have low libido, low energy, but they have different androgen sensitivity, one of them may need a higher dose of testosterone replacement therapy.
Exactly. And that's why you don't want the cookie cutter too, because you don't want to be told 100's enough for you when you don't have any symptom relief on 100. You don't get it until 200. Or you don't want to be told that you need 100 when you're getting all of your symptom relief from 70, because now 100's driving the sympathetic overdrive or gynecomastia or acne or high blood pressure, So it's very nuanced and very individual.
Yeah, that's going to be really interesting for people to hear, because I think most, at least listeners of this show, have heard guests talk about insulin sensitivity. Mm-hmm. Insulin's a hormone.
Yeah.
So the ability for insulin to kind of work, do its job, and help get glucose into cells as its sort of primary role. This idea of androgen sensitivity is super interesting.
Yeah.
Is it genetically determined, or are there things that we can do in our lifestyle to change how sensitive we are to these sex hormones?
I've never thought of that. I think about androgen receptor sensitivity all the time. And I've never thought, just when you were talking, a light bulb went off. Like, I wonder if there's lifestyle effects just similar to insulin receptors that, will degrade the receptor or drive some resistance to the androgen. I don't know. I don't think we have a good answer for that. Right now, it seems to be genetic differences in those polynucleotides like the CAG, and there's some other ones out there too. And then there's differences with the androgen binds to the receptor in the cell, and then that gets translocated into the nucleus. Some people have genetic differences in the translocation. Some people have genetic differences in the transcription translation, so the making of the DNA into a protein. So there's all of these genetic differences that you need to take into account. So not everyone needs testosterone if they're at a 300, and not everyone doesn't need testosterone if they're at a 700. It's all different.
When you walk into a HRT clinic and you get prescribed testosterone, that testosterone, at least how I see it described on websites, is called bioidentical. Mm-hmm. Is it synthetic? Is it kind of made in a laboratory? And is it different to what you might buy on the streets or in the gym?
It is made, and it's made, this one's going to be good for your listeners, usually made from soy, I think. So soy boys out there, all these guys on TRT are actually soy boys, either soy or yam, but also, a more plant-based food. So they use these plants in order to make the
That's
molecule.
Amazing.
Yeah. So it's made, but it is bioidentical. So it's, chemically identical to the hormone that you would produce. And then it's attached to an ester. The ester is something that kind of dictates the half-life. So it slowly releases because your body has these esterases that cleave it off. And so if you just did pure testosterone, you'd be hit with a boost of testosterone. That's called testosterone suspension. Bodybuilders use it. Powerlifters use it. They do a shot and go hit a lift. But you actually want a slower release of this stuff. So you usually get testosterone cypionate, which is an ester, or enanthate, which is an ester, or propionate, a different ester. And they all dictate how long it will take to break down and get into circulation.
Right. So it's not natural, which poses a problem to someone whose motto is natural is best. Like the ancestral way of living, I can see people thinking, is taking exogenous testosterone that's synthetic, is that natural? Not that I buy into that argument, but I can see that kind of might pose a dilemma to some people.
It could be. Yeah, they usually don't care when it comes to testosterone. Everybody wants testosterone.
That's an exception.
Yeah, it's definitely an exception. Like, guys will tell me all the time, like, I don't want medication. And I go, oh, okay, good. So we won't talk about testosterone because that's made by a pharmaceutical company. No, that's okay. I'm like, okay, well, you have a large fallacy here,
Yeah. The other thing that's funny about soy being used to kind of produce the testosterone, or at least I found it funny. Paul Saladino put up a video. Someone asked him to substantiate his claim that soy is feminizing. And he put up a rat study. And I know this intricately because I had to read it like 5 times. I couldn't believe it. He flashed up a rat study on screen and said, these rats were fed soy isoflavones, and it showed that it lowers hormones. And in actual fact, in that study, it specifically stated that, and I'm not by any means using this study to say that soy raises testosterone. I don't even think this is good evidence.
Right.
But his study refuted his position.
Yeah.
That study showed that the rats that were exposed to soy isoflavones had an increase in testosterone.
Right. Actually, when I talked about SERMs before, there's some thought that these isoflavones can act as a SERM, a selective estrogen receptor modulator. So they do look like estrogen enough to fit into the receptor. And if it modulates and blocks the estrogen, then maybe that causes an increase in testosterone. So there is when you look at data like that, foods, nutrition, it's all over the place. We've talked about before. You can make your claim on research, if you search for it.
What study are you going to choose today?
Right.
And what studies will you ignore?
Yeah, but it does seem like soy actually has some anabolic effect potentially through increasing testosterone, possibly through that SERM mechanism.
That's ironic.
Yeah.
Straight testosterone versus the testosterone that you would get at a HRT clinic. How do they vary, if at all?
So they shouldn't really vary. The compound should be the same. The issue with the street is that you never know what you're getting. Like any other drug on the street, you never really know what you're getting unless there's regulation behind it, coming through a pharmacy that's governed and regulated by the governments. So the issue is a lot of times, a guy is cooking it in his bathroom or his kitchen, using the pots that he cooks macaroni and cheese in, and it's dirty and contaminated. It can also have other solvents in there because you have to turn this powder into an oil, and it takes certain solvents for that. So sometimes they're highly inflammatory. So purity is the big one. They're usually actually overdosed, not underdosed, because the raws come from China. They're relatively cheap. And the way the underground market works is it's all kind of word of mouth on forums. And occasionally a guy will get his blood drawn on this source's testosterone, and they always want it to come back very high. So they always usually overdose a little bit so that when the guy gets tested and posts his results on Reddit, that he's like, oh man, this stuff's good. Look how high it's getting my testosterone.
It's marketing.
Yeah. So oftentimes I do get the occasional, 45-year-old guy who comes to me like, hey, I couldn't afford TRT. So I went on this stuff and his testosterone's through the roof. And he's not doing that purposely, so your risk is probably overdosing, but also purity is a big one. That's what I'd be most afraid of. So, what kind of oil are you getting? Are they these inflammatory oils and solvents? And is it actually clean and sterile? Because you're literally injecting this into your body. You can have infections, abscesses, etc.
Yeah.
So that's the biggest concern with it.
Can you test it?
You can. There's labs. It can be expensive. You have to send it usually to a university, or there is purity testing labs.
And then you're going to have to do every batch.
Exactly. Yeah.
Right.
So it's tough. It's tough to do the product control on that.
What if someone is just kind of averse to having injections? Is there other format?
Yeah, there's a cream and a gel. Gel came first, transitioned into a cream by compounding pharmacies. The cream's a little superior. There's pellets, which I'm not a huge fan of, but that's pretty common, popular these days. They make a little incision in you, stuff a pellet in there, sew you up. And the idea is that it slowly dissolves out.
So it more like mimics that natural production? Is that
maybe,
what it's meant to do?
But it's meant to do that, yeah. But what we usually see is it causes a large spike too. So sometimes these guys start out like 3,000 nanograms per deciliter, and then they slowly titrate off. And it's usually kind of a robust hit at first. And then there's no way of really controlling it. You got to kind of bank on the body's metabolism of it. So there's pellets, but I don't usually suggest those. Also in guys, a lot of us have pretty lean butts, and they're kind of putting them in the butt and hip, and it gets painful. So there's not a lot of extra adipose there. There's also now an intranasal testosterone spray. Can't remember the dosing protocol. It's either twice or upwards of 4 times a day that you need to dose this. So it doesn't seem like very practical for most people to remember to be nasally inhaling testosterone. But it's interesting nonetheless. And there's an oral form as well, testosterone undecuinate.
Is there like site-specific increases in muscle size with injections?
It's a good question, largely debated in the bro forums for sure. Probably not, but maybe in a way, probably more, in my opinion, via just increasing surface area because you're injecting an oil in there and it can kind of be a site enhancing oil. And also inflammation because, you're injecting that area. There are going to be immune cells that come to the area because it's a foreign invader and cause it to be a little more inflamed. So in my steroid days, for sure, my delts were so much bigger because I was injecting and they were like, blown out, and it was kind of like a site enhancement. But I don't think I got more muscle. I think that it was just inflamed temporarily.
Right. Do you think, like today, more men, guys in their early 20s are turning to testosterone, people in gym culture? I don't know if it's just me, but when I jump on Instagram and look at the size and shape of some of these 20-year-olds, I don't remember being exposed to that. Like certainly I had bodybuilders that I would I would watch documentaries on and see in magazines and whatnot, but their physiques, to me at least, looked like a little more mature, like it took them some time to get there. Now I'm seeing these guys that honestly look like they're in their early 20s and they're absolutely diced. They're huge, and I have to wonder what that does to the psyche of the average 15, 16, 17, 18-year-old male.
Yeah, it's insane. I mean, the social media and its social media around PED use, I kind of describe as a double-edged sword. On one side, now everybody's open with it, and it's great because we know, okay, they didn't get that physique using this supplement protein powder, and they're not going to go waste their money on that. And it was all unethical lying, On the other side of that, now everybody's open with it, and now young kids are exposed to that, and they see that their hero uses steroids, and they know that they could look like their hero if they use the steroids. So I don't know which one's better. Do we go back to lying about it and not telling anybody what we're doing and saying that we got this way off a supplement? Do we not talk about it? I kind of appreciate, like Sam Sulek is blowing up right now. He's never once mentioned. I mean, everybody knows he's likely on, but he's never said that he's on. He's never described his cycle. I kind of prefer that. It's like, just let it be known that he probably is on, but let's not talk about it so that he's not kind of making other kids jump to that. But yeah, everybody, I mean, because, you turn on Instagram, YouTube, whatever, and the guys are giving their cycle advice and they're saying where they get it. Now they're these research chemical companies, which are, essentially they take a chemical and they say, this is not for human use. Meanwhile, their influencers are humans that are injecting it. And, these are pharmaceutical drugs. So
it's hard because in some respects, at least if the conversation is being had and there's less stigma, then people can maybe do it in a safer way.
Maybe.
Right. If they were going to do it anyway,
right,
at least now they can have the conversations and think about some of these things we're thinking about and not have regrets 10, 15 years down the track and think, wow, I'm infertile.
That's the best part of it for sure. Because when I came up, nobody talked about it. And I was looking at the Ronnie Colemans and Jay Cutlers, and I honestly didn't know if they were on or not. Like on the bodybuilding.com forums, people would debate it. And like now that's just comical, even to you. And you're not even in the space, you laugh right there because it's like, duh, they're on. It now. But I didn't know. And then when I actually got into steroids, no one was talking about the side effects. We only talked about the aesthetic side effects, hair loss, acne. That was about it. Sometimes elevated blood pressure would be brought up, but not in the context that it should have been. No one was talking about ASCVD or the infertility or the insulin resistance, all of these things that come along with bodybuilding. Nobody was talking about. Now everybody knows. So a lot of like bodybuilders these days are prophylactically starting statins and blood pressure medications and things, which is great because it's much better for them.
Right. Well, there's been a lot of heart attacks.
Yeah.
Of dudes in their 40s.
Yes.
Which is crazy. On ASCVD, I think there is probably a lot of people listening thinking, how does HRT affect the cardiovascular system? And I think we need to delineate here between HRT, getting testosterone to within a normal range, and gym culture and taking super physiological kind
100%.
Of doses of testosterone. What do we understand from published peer-reviewed evidence in terms of the effect that this has on cardiovascular disease risk?
Really tough, but your differentiation is perfect because that's what we definitely need to do. Again, all of testosterone kind of has this curvilinear, like too low, not good, too high, not good. Same with anything, glucose, too low, too high, but testosterone is very much so that way, because we know that low testosterone hypogonadism is associated with a higher risk of ASCVD. Conversely, very high is also. But TRT, we don't have a good answer for, honestly. I mean, a lot of people have recently been quoting the Traverse trial, came out in 2023, I believe. Decent trial. I mean, it was the first randomized controlled trial on testosterone, which is awesome, because your listeners will know, the randomized control trials are kind of the gold standard, and we can glean the most amount of usable, actionable information from randomized control trials. The problem with that, in my opinion, it was only 22 months in duration, and ASCVD takes a lot longer than 22 months to occur. So they took guys like middle age, basically, and they put them on TRT. It was a cream, and they showed that they didn't have any increased risk of ASCVD to the placebo. Great. There was an increase in AFib, which was interesting, and I think an increase in clots.
And how long was that follow-up, roughly?
It was 22 months, I think, on average.
Months.
So not very long, almost 2 years is not great. You can't do anything. You can't do a statin trial in 2 years. That's a lot of the pushback on most of them. That's why we use, the Mendelian randomization, so we can get a longer time horizon, essentially. So it wasn't good enough, in my opinion, to say that. I think the prior year, there was a meta-analysis that came out that said in the mid-range, which I can't remember what they defined a mid-range, maybe 5 years or so, it didn't seem to be an increased risk. I would personally argue that if you're doing TRT appropriately, correctly, and you're just getting back into normal physiologic range, it's probably a positive or a neutral, like either no effect or a positive effect. And the positive effect, I think I could argue very well, is probably coming from the estrogen increase, because women will die of less cardiovascular events than men until they hit menopause. Then they're equalized, because their estrogen drops. So estrogen is actually the cardioprotective part of testosterone.
Right. Which then begs the question as to how drugs like Clomid or tamoxifen, does that lower estrogen as well? Like how do those drugs affect cardiovascular disease risk?
Well, actually, the tamoxifen and the Clomid don't lower estrogen, but they do bind to the receptor and cause issues. But interesting thing on the side of ASCVD with Clomid, I think it's been well known, but I'm glad that like Peter Attia talked about it openly. He talked about the effects of Clomid or clomiphene on something called desmosterol. So in cholesterol synthesis, it's a long cascade of biochemical events. And one of the products that's made in there is desmosterol. And that actually seems to be more atherogenic or more plaque inducing than the actual end product cholesterol. When you take Clomid, it is increasing levels of desmosterol. Most people don't get that checked because there's only one test that they do at the Boston Heart Study. So you may actually be increasing your risk of ASCVD if you're doing Clomid or clomiphene by increasing this desmosterol. And then there's also other downstream negatives to blocking estrogen receptors. What's really interesting is, I kind of wanted to bring this up earlier, I'm glad you brought it up, is if you put a guy on Clomid therapy and you get his levels to 700, and then you put a guy just on TRT and get his levels on 700, I would say 9 times out of 10, the TRT guy feels better with the exact same number. And I hypothesize it's likely due to the blockade of the estrogen receptor, causing some effects, usually centrally, like mood, because usually you hear it's kind of called Clomid crazies. People will feel depressed or kind of crazy when they're on Clomid. So it's just an interesting aside that, again, estrogen is very important and we shouldn't be demonizing this.
Right. Okay, let's change gears slightly and come back to lifestyle. So now we're thinking about the person who's kind of borderline, is listening to all of this and perhaps thinking, like you said earlier, like first line, think about your lifestyle. Nutrition, sleep, exercise, these things come to mind, supplementation. What can we do to kind of nudge ourselves up to a healthier, more optimized level of testosterone? So if we start with nutrition, in what ways, if at all, do our food choices affect our testosterone levels?
I think they do, specifically in the micronutrients, probably more than anything, because as we just talked about, you need cholesterol to produce, but we can make cholesterol ourselves. But micronutrients are very essential, so zinc, magnesium, selenium, vitamin K, vitamin D, all of these micronutrients are probably very important. A lot of people have a micronutrient void diet. So I would start first with really trying to get in your macros, I usually recommend like chronometer, and then have certain ranges that I tell guys to put in and try to hit those. And if you need supplementation, you can do that. The actual macronutrient or the food choice, in my opinion, doesn't argue. I mean, there will be people on either side of the aisle that are going to argue, that no animal foods will boost it and no plant foods,
high carb, low carb.
Yeah. And I don't think there's good data. I've looked all over, and like we said, there's a study to support one thing and a study to support another. So I don't think it matters that much at the end of the day. I think the most important thing that you should do is get enough calories in first and foremost, get enough protein in first and foremost, and then, get those micros dialed in.
So you say calories, does energy restriction, being in a calorie deficit, does that affect testosterone levels?
Yeah, absolutely. Yeah. So you see a lot of the natural bodybuilding guys who get, bone dry, like super low fat, and they have very low calories. Their levels will be like damn near zero. They get so low. It makes a lot of sense. You're, from an evolutionary standpoint, you're probably not in a good place to reproduce if you don't have the calories essential to be a good provider.
Kind of similar to a woman who's over-exercising, underfueling, and develops amenorrhea.
100%. Yeah, I saw a marathon runner recently who did like these back-to-back marathons, and his testosterone was like double digits, just awful. He felt terrible. So we just get him back on a good nutrition and back off the exercise, and it'll usually go back up.
That's interesting, because at least what I've read, so the flip side of that is the calorie surplus, being overweight and obese, and I believe they're associated with low testosterone as well.
Absolutely. Like everything, too low, too high, not good. So yeah, this is a more common thing is, energy toxicity, essentially, through a lot of pathways, one of which being insulin. Very high levels of insulin is actually kind of inflammatory and disrupts the hypothalamus and the pituitary. So we can have insulin resistance occurring in the hypothalamus first. And there's some papers that say that insulin resistance starts in the brain, which is very interesting. And one of those is that it reduces LH and FSH output. And then there's higher levels of inflammation. Adipose tissue is very inflammatory in nature. It produces these cytokines because our fat cells can only store so much fat. They kind of get, pushed to the brim, and they exude these inflammatory molecules, which drive inflammation. Inflammation can disrupt the hypothalamus and pituitary, but can also affect the testes. So when you're trying to get a guy fertile, you actually try to reduce inflammation as much as possible. Try to make them as insulin sensitive as possible, because that stuff can have an effect on sperm count too. So yeah, the more common of the scenario is energy toxicity, adiposity driving hypogonadism.
Right. So getting to a healthy body weight, good body composition is going to be important for testosterone.
Absolutely.
What's the relationship between protein intake and testosterone?
I don't know if I've seen any, I'm sure they're out there, but I don't know. I just, not usually an issue that I'm always telling guys to get enough protein. I'm sure if you have too little protein, you're going to have an inability to produce, the required hormones, but I can't cite any studies or anything. I would just say, I would probably put money on the fact that if you have too little protein, your hormones will be impacted.
Mm-hmm. Is skeletal muscle, or having enough skeletal muscle, is that important at all for testosterone production?
I can't think of anything in that regard either, that, a more muscled person produces more or less testosterone. I don't think that's out there. I don't see why it would matter too much. It's hard to say.
What about saturated fats?
Oh yeah, that's a good one.
So if we flip, let's move to another macro. Fats. There is a lot of discussion on social media, TikTok, shorts on YouTube, of people saying foods like eggs or butter are particularly good for raising testosterone because they are either rich in saturated fats and or dietary cholesterol.
Yeah, again, I think that's flawed in that you are just looking at the mechanism and thinking cholesterol comes first. So anything that increases cholesterol is going to increase testosterone. It doesn't necessarily play out that way. There's one study that was quoted, I think, by a prominent science figure and gets, put on shorts and reels and everything, where eating eggs increased the testosterone. They had two arms of that. One was eating eggs, one was eating egg whites. I think there's way too much variability in that, first and foremost. Egg whites are pretty much just protein. They're devoid of a lot of the micronutrients. There's too many confounding variables in there. Was it the choline? Was it the other micronutrients that were in the egg, the selenium? What was it there? Was it just the saturated fat and the cholesterol? Maybe. But then conversely, we see studies where higher saturated fat diets are correlated with lower levels of testosterone. So it's too tough, in my opinion, to tease out the data because it's all over the place. And I don't like those bold claims like you need to eat high saturated fat in order to have testosterone, because I can find a study that says the exact opposite.
Is it true, though, that you do need to have some amount of fat in your diet to support testosterone production? Is there potentially an issue if someone adopts a very a very low total fat diet? It's low in saturated fats, it's low in unsaturated fats. I'm thinking of like the 10% fat vegan diet that's often promoted.
I think you would have to definitely, I think some of the concern with too low a fat diet is that you're not getting enough of the fat soluble micronutrients. So if you controlled for that, I don't know, that would be a good study that if you just reduce fat, but then supplemented with D, A, E, K, things like that, do you still have it? Because I don't know. I don't think that study exists. I think in general, we shouldn't be too dogmatic and should have a good amount of carbs, fats, and proteins, but I don't know of any study that says that a fat-free diet is correlated with lower. And if it is that because of the fat itself or the nutrients that usually come alongside the fat?
Yeah, that's a good point. Have you seen, either in studies or with people that you've worked with, like how much can someone increase their testosterone by changing lifestyle? Like, for example, in this context, if someone is not at a healthy body weight, they lose weight, become more insulin sensitive, what percentage increase in testosterone might they see?
Yeah, really good study on this recently, 2023 Andrology, I believe. They took guys, obese guys, basically had them lose weight. And I can't remember all of the references, but one of them, taking your adiposity from one range and bringing it down to another, there was a 40% increase in testosterone. So these were obese to non-obese. I don't know the exact body fat percentage, but 40% is significant. Yeah. Especially when, you're looking at these testosterone boosters and things that people are claiming 10% increase. So great. I'm taking my 600 and making it 660. These people are having a 40% increase. That's pretty robust.
Yeah. Especially if it takes them from below, like the low end of normal, below that, into the normal range, right?
Yeah.
Is there anything else that we need to cover here with regards to nutrition and testosterone?
Nutrition, hard to say. That one's heated. We'll get the most comments on that. No matter what we say, we're going to piss somebody off in the field. But I think in nutrition, the biggest thing is focus on your micronutrients. Get enough protein, get enough fat for you, whatever that is. It's hard to say. So nutrition's I don't know. It's hard. I would say eat more whole foods, micronutrient dense foods is going to be the best way to go. But in lifestyle in general, I would say sleep is huge, definitely overlooked. Psychological health is really big and something that I really try to work with people on, both psychological and spiritual health, because all of these things will skew your levels really significantly. So when people aren't dialed in, if they're not, I tell them we need to check off every box, and really check off every box. A lot of people say I'm good, I'm good, but they're not, their diet's not good. And they're telling me they're good, but I'm like, dude, I can see you're insulin resistant. Your diet is not good. We need to work on this. We need to check off all these boxes before ever thinking about testosterone. Where it becomes difficult is there are guys who have tried everything and they're hitting a wall because their levels are so low. And what do you do with that guy who doesn't have the motivation, the drive to get up off the couch and do the work needed because his testosterone is so low? In my opinion, I think that's something where an intermediate like enclomiphene for a short period of time can be really good. Or maybe they do need TRT. It's hard. It's really hard. It's a tough discussion.
Right, just to get the wheels in motion.
Exactly.
You mentioned sleep. Is there an optimal amount of sleep? Is it the time, the duration that someone's getting every night? Is it sleep quality? There's studies that have looked at this and sort of tried to tease out what's most important when it comes to our sleep behaviors and testosterone.
All the above. I think the time, the duration, the time you go to sleep seems interesting for hormones. Not so much testosterone, but growth hormone. I think you had Kristen Holmes on, right? Is that her name?
No.
Wait, what's her name? Okay. You were on hers, on the Whoop podcast.
Yes.
Is there? Yeah. I talked to her one day. She enlightened me on this, this growth hormone production occurs at like 11 p.m. in everybody. And if you miss that window, then your growth hormone doesn't get produced. So, if you go to bed at 11, you may be missing that growth hormone output. So she was talking about the importance of actual timing, which I thought was very interesting. I'm not a sleep specialist, but it does seem like the time we go to bed makes sense. Probably when the sun goes down, we should go to sleep, and when the sun comes up, we should wake up. That's probably when we're going to produce the most amount of testosterone.
Yeah, I confused you there because she interviewed me, but we put that up on my channel.
Right. I saw that come through.
What about resistance training? Does lifting weights, does that affect testosterone levels in any way? There's this kind of idea out there, at least when I was in my 20s, everyone would say, don't skip leg day. When you train legs and you train legs hard, it will increase testosterone.
And probably so. I think it does. It's always hard to tease out whether it's just this transient spike, because acute effects are much different than chronic effects. So is it an acute effect, and does it have any bearing on the rest of the day and the year, et cetera? Hard to say. Growth hormones that same way. Then you're getting the increase in growth hormone and IGF-1 acutely, not really necessarily long-term. But I think in general, it's a good recommendation to do some resistance training. You probably will have optimal hormones if you do.
What about testosterone levels over the course of a day? When we wake up, are our testosterone levels the highest for the day and then they gradually go down, or what does it look like across a day? And does that affect when we are strongest and therefore the time of the day where we can perhaps get the best workout in?
Possibly, yeah. I mean, to answer the first question, it's producing what's called a diurnal rhythm. So that means the most of the testosterone is produced right when we wake up. So you'll have the highest number when you wake up, which is also the best time to get tested. I think you could make an argument for the opposite too, because you might want to see it when it's at its lowest. But your endocrinology usually says test first thing in the morning because that's when it will be its highest. By the end of the day, it does fall off. As to whether or not that impacts your response to resistance training, I've seen papers that say both. So I think, again, it comes down to individual variability. If you generally feel more energized and you feel better with more meals than you at the end of the day, you're probably going to have a better workout than you do first thing in the morning. And I don't think that the testosterone fluctuations within a normal physiologic range are going to have that much bearing on your hypertrophy, which is the argument against a lot of the testosterone boosting supplements. Like I said, if we're doing a 10% increase, you're bringing it to 60 to 660. That's clinically insignificant. When we're talking about testosterone having these massive hypertrophic benefits, we're talking about super physiologic. We're taking that 600 and making it 2000.
Right. Testosterone boosting supplements. You went there. So let's double click on this. What are we talking about here? What kind of compounds?
So the ones that have gained the most popularity, again, through an influential, science, social media figure would be Fedoja and Tonkat Ali. Those are probably the most. There was Tribulus for a while when I was coming up. Everybody talked about that.
Tribulus was like when in my 20s, that was the big one.
Right. Everybody talked about that. I don't know what happened to it. I don't even know the mechanism of action. No one talks about Tribulus anymore, but it's now, Tonkat Ali, Fedoja, and then to an extent boron, because boron can have a suppressive effect on SHBG and potentially increase the free. I haven't seen good data on either one of those. It's hard. I mean, I have seen guys come in with very high LH.
On Fedoja and Tonkat Ali, which they're extracts from herbs.
Yes.
They are?
Yeah. And the Fedoja, I don't think we fully understand the mechanism. I think we know kind of it's going to increase LH and FSH because it can really only work one way. It can only increase LH and FSH or reduce SHBG or be a LH mimetic and stimulate the testes. So it can work in 3 different ways, I guess. But it seems like Fedoja probably increases LH and FSH. I haven't seen good data on it. I think the only study that everybody puts their hat on is that there was a 5-day rat study, I believe. It's called Aphrodisiac Effects of Fedoja, and they increase the testosterone. And then there's another study that luckily does get cited where they talk about testicular toxicity that occurred. It was at high doses and again in rodents, but
the question there is it metabolized the same way in humans?
Yeah.
And how do you take the dosage from that study and sort of extrapolate that to humans?
Yeah.
And So there's no human data that you know of that looks at safety.
Fedosia, no, not that I have found.
Interesting.
Yeah, but Tongkat Ali does seem to have some pretty good studies. I know one time we were talking, you sent me one. That was a really good study done with the forearms. I don't know if you remember that. So I think they had like a control group. They had a group that was taking Tongkat and exercising. And then, but it was interesting because at the end of it, it seemed like they only got an increase if they were exercising.
Right.
Which they didn't do an exercise only group, which I wish they had that as an arm, because that would tell us, was it just the exercise that increased the testosterone? And what was it, like a 10%?
Yeah, it was 10%.
Yeah, so again, so insignificant in my opinion. I would not waste my money on the 10% increase in testosterone. It's never going to be enough to feel it.
So what about boron? So, I mean, let's bring people up to speed with some of my test results. Sure. Which I've shared these online already, but maybe I'll share them again. But I had a test done, this was, I'm going to say December last year. And total test was at 648 nanograms per deciliter, which was considered optimized according to Inside Tracker's ranges anyway.
Yeah, I would agree too.
But my free test, Inside Tracker says free test, they have a normal range, which starts at 4.6, and then they go up to an optimal, which ends at 22. Mm-hmm. And mine was at 9. So I think you and I spoke, and I said to you, is a free test of 9, should I be concerned with that? Is it too low? And we spoke about possibly supplementing with boron and seeing if that would increase free test. Right. So talk to me about boron, and I guess also whether someone with results like mine, where total test was at 648 and free test was at 9, if those numbers are good.
Right. So first on boron, the idea with boron, what it does is potentially have a suppressive effect on SHBG. But I've tried to dive into literature and see, and it seems like it has more of a binding effect to SHBG. So potentially binds and then takes that spot on the SHBG so that testosterone can be liberated. Because oftentimes you don't see SHBG decrease. In fact, I saw yours actually increase, right?
Well, this is the interesting thing. So I did 8 weeks. I think I was doing 6 milligrams a day. Mm-hmm. That was the dose,
pretty standard.
Right? Yeah. And my SHBG went up from 39 to 60, which they flagged as high.
Right.
Total test went up from 648 to 739, which was like a 13% increase. And free test just stayed exactly the same. So if anything, because my total test went up, now my free test as a percentage of total test is actually down.
Right.
I don't know if that's a problem, because it's probably more like the absolute amount that matters.
Yeah. And again, when on your first question as to a guy has similar levels to you, first and foremost, I'd ask, like, how do you feel on that? And I think most people looking out would be like, you epitomize what they would want to be. You know, you're
like, I feel great.
Yeah.
I feel strong in the gym. I have a high sex drive.
Yeah, you're motivated, you're successful, you know, you're lean, muscular, strong. You said you have a high libido. So, I mean, why would you need to increase? You know, so if you felt good to begin with, I wouldn't get too hung up on the number.
I think it was psychological. You see the range,
yes,
and you think, okay, I'm in what is considered normal / optimal, but it's not like right at the far right.
Right.
Should I be optimizing? And what I'm hearing from you is you might make changes, get these 10, 15% increases, but not have any change in, like, subjectively how you're feeling.
Right. And did you?
No.
Yeah. So did anything change?
Nothing
Good
changed.
Or bad?
Nothing changed, except for total test went from 648 to 739.
So now psychologically too, you're probably a little bit distressed, like, oh no, I'm now out of the optimal range of free. And that's why I don't, in one way, like the endocrinologist will say, without symptoms, don't test. I don't agree with that, because I think everybody should have this autonomy. And I like, you know, just being able to give people the ability to look inside their body and see where their hormones are. But it also becomes problematic when you don't understand the nuances. And then some of these TRT clinics have like red and green only on their ranges. So like on yours, you would be all in red because your testosterone wasn't up to 600. So they see that and they're like, red? Like, I'm in red on testosterone, because they think 601 and higher is green. Like, I must need testosterone because I'm in red. And it's so like...
Oh, that's what they're doing at the clinics?
Yeah. I mean, similar. I mean, Inside Tracker's pretty good. At least they have this range of like, you know, red to orange, yellow, red, right. You know. But a lot of the clinics will put you in what they deem suboptimal. And then you're thinking, oh, these are the reference ranges for all of my peers. Like, I'm in the red, I'm bad, I need TRT. And they've just psychologically convinced themselves when they just went down the rabbit hole to see where they're at. But now they're feeling the symptoms because they're like, well, maybe, that one time I was a little stressed out with that really hot girl and I went limp, so I must have lots of, so it's like, it's hard because so many guys run into this issue day in and day out.
The other interesting thing on that latest blood test I did, and this might be because of the time. So I had a mobile phlebotomist come out, and they came at 5 a.m. So I was testing at like 5:20, super early. My cortisol was considerably higher.
Right.
I also had moved from Australia to LA. There was a bit happening stress-wise, but the cortisol had gone up from like 15 to 23, and they flagged that as like pretty high.
Right.
And I wondered if there was any evidence that boron could do that, or if that is likely just because I did my testing so early in the day.
I would say likely because you did your testing first thing in the morning. This happens all the time. And then unfortunately, very unethical people will, read that and then convince them that they need all these adaptogens and everything to lower your cortisol, when the fact is, like, cortisol is fluctuating all the time. If you did this a few hours later, you'd probably be normalized. We know cortisol spikes first thing in the morning to wake you up, to increase your body temperature, wake you up. So I went and bank the moral of the story on all the hormones. You can't make any inference off of just one reading. That's for sure. You should get multiple readings. And then you should really go, particularly in like testosterone, for example, subjective is so very important because, as we mentioned, some people have a 200 and feel great. Other people have a 500 and feel awful. And so neither one of those people should be told that they either need or don't need, because they really need to be looking at the subjective feelings of that person. And everybody's different.
I heard Peter Attia once talk about something that he uses with certain patients who have a low free test, was supplementing, well, not supplementing, it's probably the wrong word to use here, prescribing Anavar. And I believe he said he would use 10 milligrams 2 or 3 times per week, and that would lower SHBG.
Right.
And in doing so would increase free test.
Correct. Yeah. It can. So oxandrolone, Anavar is the brand name, oxandrolone is the generic name, is an anabolic androgenic steroid in oral form, very popular in bodybuilding communities, especially in cutting phases or in female athletes. One of its main mechanisms of action is a very strong suppression of SHBG, liberating or increasing the levels of free testosterone. So it can be used in that way. One thing I would caution people with is that it is an androgen. And in that feedback loop, there are some androgen suppressing effects. And so if you take an androgen, oftentimes without a testosterone base, you run the risk of suppressing your natural production. Not only that, but that androgen is not being aromatized into estrogen. So some guys will go on like an oral only Anavar cycle, and they have their androgens met through the Anavar, but they don't have the estradiol, and they feel awful. And it's terrible for their cardiovascular system, for their neurological system. So bodybuilders all know if you're going to do anabolic steroids, you need a testosterone base. So I think it works really well in individuals already on TRT. I would caution people not on TRT to probably not do it. There are a few studies where low doses of Anavar taken alone didn't suppress LH and FSH, but in practice, you see guys come in suppressed all the time because a lot of guys want to not pin, but they want the steroid results. So oral only cycles are very popular in younger guys because they don't want to pin yet, and they get some Anavar online, they take that, and they come in and their testosterone's at 0. So it happens all the time.
Why are compounds like Tren? What is Tren?
Yeah.
Now we're kind of creeping into, I guess,
good old steroid talk.
Yeah. But there might be people, I know certainly on Reddit, people talking about Tren.
Yeah.
Is it worth it? Can people get similar types of gains with other compounds that are safer? Is Tren highly toxic?
Yeah. So full transparency, I have run a lot of Tren in my life. And it's one of my biggest regrets, honestly. I have a hard time because a lot of young guys come and talk to me and I feel so like a hypocrite, because when you're older, you're like, man, that was so stupid. I wish I didn't do that. Tren, I believe, is a progestin. So it binds to the progesterone receptors, and it's very strong at what it does. It's very anti-catabolic, which is really how it works the best probably. And it has some non-genomic effects where it will increase kind of aggression. It really changes your mood. But where it shines is for bodybuilders in particular who are in a massive caloric deficit, who need to preserve muscle mass. So bodybuilders don't usually introduce Tren until they're dieting, and then it's a drug used for its anti-catabolic effects. So you can be on very low calories and still preserve muscle, which is great, and it's awesome for that. But it also changes your mood, changes your brain. It's probably very kidney toxic, atherosclerotic inducing. So there's a lot of downsides to it, and very little research in humans, almost none. I think there's one study, I can't remember if it's German or Russian, from like the 70s or something, and the bros have translated it, and it kind of gets passed around, but it's one and only study. And the rest of it's using cattle. And so it's just scary. You're using a cow drug that we know probably is kidney toxic, cardiotoxic, neurotoxic is a really big one.
I'm guessing you didn't know any of that or much of that.
No one talked about it back when I was doing these things, Again, it was, if you're not getting these aesthetic side effects, you're not losing your hair or having acne, you're probably fine. Keep pushing. And we actually had people telling us like, oh, pros are doing these exorbitant amounts, like 3,000 milligrams of Tren a week. And, there was on the forums, and everybody was reading this and just thinking like, oh, that's why they're so much bigger than me. And that's what I really got kind of fascinated in it, because I never grew to those levels. I definitely had an impressive physique, but I would never become the Chris Bumstead or the Ronnie Coleman. And I realized I just don't have the genes for this. And that's why I try to tell other people. That's why I was open with my use. I decided I'm going to be really open with this and give my story, because I did a lot of stuff stupidly, probably put my health at risk, thinking that I could achieve what they were doing if it was just I did a little bit more, or maybe I had the wrong brand. And I was always lying to myself, where I've trained now with a lot of professional bodybuilders. I have a lot of friends in the space. Most of them aren't really running that much. They're just these genetic anomalies that, they do an arm workout, their arm grows an inch. It might take me 2 years to get that same gain,
Right.
They have these genetic differences. So I try to impart that on younger guys. Like, you'll probably never look that way. Don't go down this road, because you're really risking your health.
Right. Getting realistic expectations.
Yeah, for sure.
What would you go back and say to yourself? Well, how old were you then? What was that kind of on-ramp? What did that look like for you?
Yeah, I started, I think I started training when I was like 20. Probably by 23, I was like, all right, I think I've maximized my full potential.
And you see a lot of big guys in the gym as well.
Yeah, and I didn't. I hadn't even learned how to train or anything yet. I started way too early, but I was like, all right, I'm going to start testosterone. I did my first cycle and was very disappointed, to be honest. I felt good, put on some muscle, but I was like, man, that wasn't as cool as I'd hoped, because I really thought I was going to transform and no one was going to recognize me. And I would see friends and people were just like, I'm like, damn, can't you see? I'm huge, aren't I? And like, no, yeah.
With adults.
Yeah, exactly. So I'm like, that must have been a shitty compound. Like, I need to go to another distributor, is that problem? So I'm going to try a new guy. Same thing happened. And then I'm like, I need to add more. And I already started a really high dose. So you used to start at like 500, and not to put out like doses and tell people what to do. But nowadays, guys are starting a lot lower, like maybe 200 a week. But we were all starting at 500. And so my ceiling was pretty low too. To get up to 1,000, it'd take me long. And now I'm running a gram of gear and still not morphine. And
were you getting any side effects from that?
I would have the occasional like acne. I kept my hair for a long time. I still have hair. I just decided to shave it off. But not really. I probably had elevated blood pressure, but no one was telling you to watch it. And luckily, I always followed a pretty low-fat diet, so low-saturated fat diet, which a lot of the bodybuilders did. So I did measure my lipids sometimes, not as much as I should have, but they were always pretty low. And I also never took any aromatase inhibitors, because guys were starting to become kind of savvy to the fact that we probably shouldn't lower estrogen. So I think I had the estrogenic protective effects too, which I'm happy about. There was a lot of years of abuse that I didn't really get the results that I wanted. And then funnily enough, like probably my last cycle, maybe 4 years ago now, it was a very small amount. And I just dialed my diet into the T, and I did really good progressive overload training. Like, I was perfect on every single lift. I blew up. And finally, everybody's starting to be like, dude, you're so huge. And I'm like, I'm on the littlest amount of gear now, but I did all the other stuff right. What a surprise. I can't believe it took me 10 years to realize that crap, Like, if I would have just trained right and ate right, I would have had a plethora of more gains than all the steroids that I took because I was listening to some idiots on the forum.
So that is, you just answered the question I was going to ask you, but that's the message that I'm guessing you would go back and
100%,
say to yourself.
I mean, it's so hard again, because it's like, I feel like a hypocrite, you know, like telling guys like, don't do this, but I understand the psychological desire to be bigger. The bigorexia is a real thing and it's so hard, but I tell everybody, for when it comes to anything, you know, your 15-year-old self is not your 25-year-old self. Your 25-year-old self is not your 35-year-old self. Probably won't be your 45-year-old self. So really hard when you're that young to look at what you're going to be thinking 10 years down the line. But if you can put yourself in those shoes, and now I'm so much more concerned with my mortality, with my, you know, I'm like, man, did I take a few years off of my life? Does that mean less time with my wife and my grandkids and things like that? You know, it's like, that sucks. So was it worth like taking a cool picture for Instagram and having a few girls hit like? I don't know.
Yeah. And you say it's hypocritical, but I just think that's wisdom, really.
Yeah.
You know, through your lived experience, you can share that and help others not make the same decisions, mistakes, for lack of a better word.
Yeah.
And that's powerful.
And I'm on TRT now and wish I wasn't. I mean, I had to travel here and I got to think about, now I got to check these through TSA and make sure that my syringes don't get confiscated. And I don't want to. I don't feel any different. I keep my levels relatively low. I keep them at like 600. I keep them at your ranges.
Is that because of the years of using exogenous testosterone, your machinery is not going to produce enough testosterone?
Yeah, I haven't tried. So I've said this on other podcasts and people are like, well, he hasn't tried. And yeah, I'm just afraid to be honest. I don't really want to go. I have such a busy lifestyle now too, that I feel like I cannot afford to go through a hypogonadal state and try to build it back up, because I work like 7 days a week. I have so many different ventures and things going on that it's hard for me to be like, I'm going to try to reset. I might be able to, maybe I could. And maybe if I ever get to a point where I don't need optimal levels of testosterone, I could try. But it is something that I wish I wasn't on, because again, like I said, I've posted multiple lab works on my YouTube and things. My levels are always around 600, and those are your levels. Right. You know, there's a small argument to, I might have better muscle building capacity than you do because my levels don't fluctuate.
But you do have bigger shoulders, so
those are past. You know, I've shrunk a lot over the years, but your levels are on that diurnal rhythm and mine's not. But how much that translates into, you know, muscle building, I don't know. But I would say somebody on TRT probably has a slight advantage. And
do you have kids, or you want to have kids?
I don't have kids. Don't know if I want to or not. It's hard to say, but I don't know. Yeah, I don't know. My wife and I had this discussion recently. It's like, would we be able to? I'm not sure.
Yeah.
Which is scary.
You've inspired me. I've never done a sperm test.
Yeah, you should.
You've inspired me to go and do one.
You should.
Is it just sperm count that you're looking at, or is there other kind of parameters?
No, there's also the morphology. So basically like the build of it, like, is it, you know, a deformed one or is it a strong one? There's the, how well that they swim, so their motility, and that gets impacted a lot by steroid users as well. There's a really interesting trope, if you will, or like cliche, that bodybuilders have female children, which they almost always do. I don't know if you've noticed that or heard that, but bodybuilders almost always have females. And there's thought that it's all the oxidative stress that kind of changes the sperm and pushes them towards female. That's very interesting. Guys on steroids usually have females.
There you go.
But yeah, that's all to say that stuff impacts your fertility too. So there are some guys with large counts, but their motility is down, their morphology is off.
Cool. Off to the sperm bank. Is it a sperm bank?
Sperm, I guess so. Yeah.
Testing center.
Yeah.
Laboratory.
Right.
Anyway, I'm signing up. Thanks, mate. Is there anything that we didn't cover today that you wanted to?
Oh man, I feel like we could go on for hours more, but I mean, at the end of the day, I would say this stuff is very complex. It's hard not to get caught up in the numbers and the social media of, you know, all of your issues are just, you know, they're going to be resolved with this injection. Remember that it is a business. It's a very, very lucrative business for a lot of these companies, and they don't always have your best in that mind, you know. So I would definitely be considerate with that. And then comparison, you know, is a tough thing too. Like, you are not the guy in the gym, and you may never look like that guy. And TRT certainly isn't going to get you there. That guy didn't get there because of TRT. And if he did, he's probably a genetic mutant. And unless you know for a fact that you are too, probably avoid that. And again, you know, consider what 10-year-old or in 10 years you will be thinking about.
Right.
So,
And
many things.
And based on what you've said today, at least something that's become really clear for me is there's probably little point comparing your testosterone levels to someone else's.
100%. Absolutely. Yeah. Definitely.
Well, Adam, thank you so much.
Of course,
You're a
man.
wealth of knowledge. I appreciate you coming on and sharing all of this with us.
Of course, it was awesome.
And all of your personal experience as well, being
Absolutely,
super open to sharing that and vulnerable.
Of course.
Really appreciate it.
Thanks, man. Appreciate it.
There you have it, friends. I hope you enjoyed this episode. If you did and want to stay up to date with future episodes, be sure to hit that subscribe button on YouTube and follow on Apple or Spotify. Finally, thank you for showing up and the effort that you're making to take control of your health. I look forward to hanging out with you again in the next episode.